Good evening. So I am going to be discussing PCOS tonight. And PCOS is actually quite a common disorder. It's usually women of reproductive age, so anyone after the age of puberty, so after your periods have started, and it can range even right up until the age of menopause. The age of menopause in women with PCOS is actually sometimes extended as well. And so in terms of what PCOS looks like, there are quite a few famous people who have been quite vocal about PCOS. Emma Thompson's, for instance, Victoria Beckham's been quite vocal about it and the difficulties that she went through in terms of trying to get pregnant. So there are quite a few people who suffer from PCOS. The actual statistic is about 1 in 10 women of reproductive age will get a diagnosis of PCOS. There are some people who don't actually get diagnosed with PCOS. And in these women, they will continuously start to suffer from the symptoms and the signs of PCOS, and they never actually know why they have those signs and symptoms. So a lot of women will actually get diagnosed when they actually come and see me, and I'm a reproductive endocrinologist and infertility specialist. And so they will come and see me having had difficulties getting pregnant, and that's when that diagnosis comes through, actually. And I actually did diagnose a patient this afternoon with PCOS, and we went through the whole gamut of the explanation of her symptoms and things like that. So PCOS was first actually documented in 1936 by Leventhal and Stein, and they documented it as women who had multiple cysts on the ovaries. But the name PCOS is actually a little bit deceiving, polycystic ovarian syndrome. So it's not actually cysts. What PCOS actually is the little follicles inside the ovary. So you're born with about 1 million little follicles and eggs inside the ovaries. By the time the period starts, it drops down to around about 500,000 every month. When you're having regular cycles and ovulating, you're ovulating 1 egg, but you're actually losing about 200 to 500 eggs. So the brain usually sends a message down to the ovaries to tell the ovaries to start growing those 200 to 500 eggs, and then one gets picked to ovulate and the other ones die off, which is why most women will end up going through menopause when they get to their 50s, because they've used up all of the eggs. Now with PCOS, what happens is that those little eggs inside the ovary, the brain will send the message, the little eggs inside the ovary start to grow, but a lot of them start to grow, and they produce estrogen, which then feeds back to the brain to say, stop producing the FSH. But the brain gets a little confused and increases another hormone called LH. And the LH is supposed to be for ovulation. But what happens is that the LH starts to get higher than the FSH, and then that message of the FSH gets suppressed. So it's kind of like a vicious circle in that your brain is sending messages to the ovary is giving contralateral messages back to the brain, and you never actually end up growing that one follicle that you need for you to ovulate. And what happens is that continual estrogen that you're producing actually gets converted to testosterone. And that's what then gives some of the signs and symptoms of PCOS. So the main signs and symptoms that some women will experience with PCOS is going to be irregular periods. And the reason for the irregular periods or few periods is that the brain, as I say, is sending the message. The ovary is not receiving that message well enough to actually grow one follicle and ovulate it. So what happens is that the eggs don't get ovulated and they stay inside the ovary. And so when you ovulate, usually what happens is the little follicle you ovulate from will then stop producing estrogen and convert then to producing progesterone. And that progesterone is then responsible, if you get pregnant, for keeping the pregnancy in place until the placenta develops at 8 weeks. What happens then is that progesterone if you don't get pregnant, drops, and that causes a period. Now, because you're not having that whole cycle of the ovulation, the progesterone rising, and hopefully supporting a pregnancy, that's why you don't get a period then with PCOS. So with PCOS, the cycles, in terms of the length of the cycles, which are the days of the cycles, are usually prolonged. So that means that they usually are more than 35 to 40 days. So people with PCOS will usually have cycles that are prolonged. So anywhere from over 35 days, some people will have 90 days, some people even just get one period a year, and some people need medications to actually bring on a period. So that's the first part of the diagnosis for PCOS. And the criteria for the diagnosis for PCOS is actually the Rotterdam criteria, which is from Europe, and it was developed about 15 years ago as the criteria that would be useful in diagnosing PCOS. So the second part of the diagnosis of PCOS is actually having elevated androgens, and androgens are the male hormones, testosterone, DHEAS, things like that, DHEA, DHT, things like that, which are high in males, but in women they are at a lower level. Now with PCOS, what happens is, because the estrogen is getting, the extra estrogen in the ovaries gets converted to testosterone, the testosterone level in women is usually higher. And that's what then causes acne and dark skin patches and things like that. It also can affect the hair growth. So you can either have excess hair growth, or some women will experience hair loss. So we never know which symptom and sign you might get in terms of how the androgens actually affect your body. And initially, the diagnosis was thought that you had to have abnormal hair growth in 8 different areas of your body. But actually now we've moved away from that, and we're now really more thinking of it in ways of that it's bothersome to the woman in terms of how much hair growth or hair loss they have. And also that it's not genetic, because some cultures and some races will have more hair growth than others. So it's a little difficult to use specific hair growth in certain areas as part of the diagnosis. So now we rely more on whether it's bothersome or not, and we also rely more on what you feel that is excessive hair growth or hair loss, and acne and dark patches, and then also the blood testing as well. And then the third part of the diagnosis is going to be ultrasound findings. So I do a lot of ultrasounds day in and day out as a fertility specialist. And essentially what we're looking for are those little follicles that I was telling you about. And those follicles, we can see them on ultrasound, not all 200 to 500, but we can see a selection of them that will die off that month. Now, as I say, with PCOS, they're not dying off, so you have a lot of those follicles. So sometimes we usually will see more than 18 follicles in one ovary, and a lot of times the follicles get pushed to the outside of the ovary, so it almost looks like a string of pearls. So when they first described PCOS in 1936, that was how they described it, as that string of pearls appearance on the ovaries. Okay, but now we also have included the volumes of the ovaries, because sometimes what can happen is that if you haven't had enough ovulations, that you actually have lost some of those eggs, you can have that string of pearl appearance, or have a lot of follicles inside the ovaries for other reasons and other diagnoses. So that's why we also want to have the volume of the ovary. And it's usually one ovary that has a volume of more than 10 cubic centimeters, so measured in 3 different dimensions. Okay, so for the diagnosis of PCOS, you only really need 2 out of those 3 diagnoses, 2 out of those 3 signs and symptoms: irregular cycles for the elevated androgens that cause signs and symptoms, or the elevated testosterone, and then the ultrasound findings. Okay, so I'll start off by speaking about if women are not trying to get pregnant. So the reason why we are interested in whether or not someone has PCOS is because it can cause some medical problems and be associated with medical problems. So some people with PCOS will have abnormal thyroid function as well. Some people with PCOS may also have high blood pressure. Some people with PCOS may have high lipids in their bloodstream. And then other people with PCOS may also have elevated cholesterol. And sometimes it can cause pre-diabetes or actual diabetes from what we call insulin resistance. And insulin resistance is when your body produces enough insulin from the pancreas, but unfortunately, the cells in your body aren't recognizing it very well. They're a little bit resistant to the insulin that you're producing. So that's what we call insulin resistance. And so with the elevated number of follicles you have from PCOS and also the elevated estrogen and testosterone levels, that can lead to that insulin resistance. And that insulin resistance sometimes shows up as those dark patches that some people will have with PCOS. Okay. And so for those who are not trying to get pregnant, a lot of times we're managing those signs and symptoms that are associated with PCOS. There's medications you can have for the excess hair loss. There's different things you can do in terms of having regular cycles. Most people believe that women should have a period every month, but actually it should be every 3 months at the least. So sometimes what we'll do is there's different hormone medications that can be used to regulate cycles, either that you take once a month or once every 3 months, or you can actually take birth control pills, which basically will make you have periods every month with that withdrawal. Okay. And then, as I say, for the hair loss, there are different medications that we use to try and reduce those signs and symptoms. And then for acne, we work a lot with dermatologists who will help with the skin conditions that arise from having PCOS. One thing that I've noticed as well is that there is one other symptom that's not discussed a lot with PCOS, and that's actually the psychological aspect of having PCOS. And we found that quite a few women are actually depressed and have anxiety surrounding their diagnosis, and particularly when they have these signs and symptoms, it doesn't get addressed, or it's attributed to something different. So we always address it, and I always, make sure that if you do show signs and symptoms of depression or anxiety or any other signs and symptoms like that, it gets managed appropriately. And sometimes even just having the diagnosis and knowing what the diagnosis is and understanding the disease a little bit more and knowing how to manage it in whichever way that you decide to manage it, that can sometimes help alleviate that depression and the anxiety associated with PCOS. Okay, so we actually had quite a few questions that came in surrounding this webinar, and some of them also asked about diabetes risk with PCOS. And as I discussed, you can get insulin resistance, and so we would always check your hemoglobin A1C. We can also check your glucose, and we can also check insulin as well. There was a question about whether women can get cancer, and there is a small risk of cancer. So that's part of the reason why you need to have a period every 3 months at least, because you want to shed the lining of the uterus and make sure that you don't develop any abnormal cells or polyps or anything like that, that can then sometimes the cells in that transform and can actually become abnormal and sometimes lead to a cancer. So PCOS doesn't necessarily straight away cause cancer, but if you're not having regular periods and shedding the lining, then the cells inside the lining of the uterus can actually transition and become abnormal and sometimes lead to a cancer. PCOS doesn't necessarily cause heavy periods or painful periods. A lot of times it may be associated with other things like fibroids or endometriosis. There was a question about whether PCOS causes miscarriages. So it's a little, one of the things that some people have suggested is that women with PCOS don't release as much progesterone because the ovulation may not be as robust as in a woman without PCOS. However, when ovulation occurs, as I was saying earlier, that follicle that the egg has been released from that ovulates will then start to produce progesterone. And that progesterone should be able to maintain a pregnancy. And if it doesn't, then again, as I said, I'm a fertility specialist. So we will usually supplement with vaginal progesterone or sometimes injections as well, just to make sure that the progesterone levels are at the right amount that they should be. Just speaking a little bit more about pregnancy and PCOS, there is an increased risk of getting diabetes in pregnancy with PCOS. So your OBGYN will usually monitor that during the pregnancy and also monitor the growth of the baby during the pregnancy as well, just to make sure that that does not develop. And then the other question was, does PCOS cause yeast infections? So because of the hormonal imbalance that sometimes happens with PCOS, there is sometimes the risk of the actual microbiome of the vagina changing, depending on the changes within the hormone levels. So some women with PCOS may get recurrent. And then there was another question about, can PCOS be cured? So unfortunately, PCOS, we haven't found an actual absolute cure. We don't really know what the actual cause of PCOS is. There is a genetic aspect in that 25% of those diagnosed with PCOS may also have a family member or relative who has also been diagnosed with PCOS. So there is a genetic aspect to it, but we don't actually know specifically what causes it. We usually just manage the signs and the symptoms of it. And then particularly in my line of work, I'm managing a lot of times pregnancies or women trying to get pregnant who have PCOS. There was a question about cyst rupture and PCOS. As I say, with PCOS, you have all the little follicles inside the ovary. You don't necessarily, PCOS doesn't necessarily cause cysts. So the name's a little deceiving in that it's polycystic ovarian syndrome, but it's actually little follicles that are inside the ovaries, and they just are not releasing the eggs from the follicles. So if you have a cyst with PCOS, it's likely that it's actually just a cyst, which you may have developed even if you didn't have PCOS as well. So PCOS doesn't specifically cause cysts, but sometimes the cysts can also take time to resolve with PCOS. That's a very good question. So the likelihood of pregnancy with PCOS is actually very high because we know what the reason is for not being able to get pregnant, and that's for not having regular ovulation. So you're not actually releasing the egg that has to meet the sperm inside the tubes to make the embryo that then gets pushed into the uterus to implant as a pregnancy. So a lot of times what we'll do is we'll start medications. If you're not already ovulating on your own, we can start medications just to help in terms of that, the follicles growing inside the ovary and one of them getting released, just because the brain is not necessarily sending that hormone, FSH or follicle stimulating hormone, for you to grow the follicle and actually ovulate it. And then sometimes even if the brain is sending that hormone, your LH level, which is responsible for the LH surge, when people are doing ovulation testing, that's actually the hormone that you're testing. You're not actually testing ovulation, you're testing the release of that hormone. Whether the ovary responds to it is another story completely. So because it's elevated with PCOS, a lot of times the ovulation sticks don't work. And that was actually one of the other questions as well. The ovulation sticks don't work. So we have to give you medications to help you grow the follicles and actually ovulate the follicles. Doesn't necessarily mean that you need additional treatments. Some OBGYNs are very comfortable prescribing these medications in the office. And so you don't necessarily need IUIs or IVF if you have PCOS. A lot of women are able to get pregnant with just that additional support to make sure that you're actually ovulating every month. So pain is usually related to a couple of things during periods. So it can be related to the actual uterus. The uterus is actually a muscle. So what happens when you have periods is that you have little contractions, almost like labor contractions of the actual muscle of the uterus. And sometimes that happens when you actually have your period, because what happens when you shed the lining is that some chemicals get released that can actually cause those little contractions just to help with shedding the lining. In some women, that's a little bit more robust than in others, and that's what causes that cramping pain that you feel, almost like labor pains that comes in waves and waves and waves. And so sometimes taking pain medications, particularly ibuprofen and things like that, can actually help with that cramping, because as I say, the uterus is a muscle, so it responds very well to non-steroidal anti-inflammatory medications like ibuprofen and Motrin. And some women will also get pain from outside of the uterus, so just within the pelvis as well. And that pain is typically due to endometriosis. So what happens is the inside lining that you bleed and shed every month actually infiltrates the rest of the pelvis and sort of seeps out into the muscle of the uterus, again causing that contraction pain, and then also into the pelvis and the ovaries. So that's usually endometriosis causing pain during periods. And a lot of times it starts actually a few days before your period actually starts. And again, it does respond quite well to taking non-steroidal anti-inflammatory medications, but we actually recommend starting that 1 or 2 days prior to the period, just because we know that the longer it's on board, the better, and actually taking it regularly on a schedule during that most painful time of the period. What medications are prescribed for PCOS while trying to conceive? So a lot of the OBGYNs will prescribe metformin. Metformin is supposed to help with that insulin resistance we were discussing a little bit earlier, but not all women will have insulin resistance. They're different phases of PCOS. Some women don't have the issue with weight gain with PCOS and some do. So metformin helps in terms of helping with that insulin resistance, helping with maintaining weight loss, and then sometimes that can trigger ovulation. Typically, we tend to, as fertility specialists, we tend to use metformin more for when you're doing an IVF cycle to help with improving the quality of eggs produced during an IVF cycle. But in terms of medications that we typically prescribe, the medication that's been shown to be the best medication for causing follicle growth and ovulation during with PCOS is a medication called letrozole or Femara. And it's a pill that you take for 5 days, cycle day 5 through 9 usually. So it's only 5 pills. It sometimes causes some side effects like just mild headaches, breast tenderness, nausea, hot flashes, mood swings, but you're only taking it for 5 days. So the symptoms usually resolve after those 5 days. And then we typically then watch as a follicle is growing. And then because remember, we were talking about that the LH hormone is typically elevated. It's difficult to see, to actually know when you're ovulating. So we give you an injection, and that's an HCG trigger injection. And what the trigger injection does is it sort of simulates the LH surge that you're supposed to get to actually make you ovulate. So that trigger shot is what actually makes you ovulate. And it usually takes the ovary 36 hours to respond to the trigger injection after you've ovulated. And then we discussed a little bit about the possibility of needing progesterone supplementation if needed. We also do use another medication called Clomid. Some women can actually be a little bit resistant to Clomid when they have PCOS. So typically we start with the with letrozole, which is going to be the recommended medication. But Clomid works in a similar way by growing follicles, except Clomid works on the brain, while letrozole works directly on the ovary to make the follicles grow. Both of the medications have risks of multiples. The risk of multiples is a little bit lower with letrozole than it is with Clomid. The risk of multiples with letrozole is around about 8 to 11%, and the risk of multiples with Clomid is about 8 to 13%, just because of the way that it works. It increases the FSH production from the brain, while letrozole works directly on the ovaries. some women actually end up needing to use injectable medications if they're resistant to the Clomid and the letrozole. And these injectable medications are similar to the ones that we use in IVF, and it's the FSH, which is similar to the one released by the brain, except we give it to you as an injection, which you take every day, usually for around 5 to 8 days as well. So that's another medication used for women with PCOS trying to get pregnant. That's a good question. So quite a few diets have been studied with PCOS, and they haven't necessarily been shown to improve the signs and symptoms. What they have been shown to do is to help with weight loss with PCOS, and that's helped then sometimes trigger ovulation. But weight loss sometimes does not trigger ovulation. So we don't tend to stress that as much. We usually just stress that if you're wanting to lose weight or have a healthy diet, do it to be healthy so that you can have a healthy pregnancy as well, rather than actually, wanting to lose 50 pounds in the hope that, you'll start ovulating, because it doesn't always happen. As I said, metformin is used partly for insulin resistance and partly to help with aiding with the weight loss with diet and exercise. But again, metformin has a lot of side effects, which a lot of people can't tolerate, a lot of GI side effects, diarrhea, bloating, acid reflux, nausea, cramping. So some women won't be able to tolerate metformin at all. And a lot of times, as I say, I typically will use it in combination either with Clomid or in combination with doing an IVF cycle. There was a question about libido, about whether PCOS causes changes in libido. So again, because of the hormonal imbalance, there can be some changes in the libido, either lowered libido or higher libido, particularly because the estrogen gets converted to testosterone. So we, again, it's an individualized thing where we don't know how it's going to affect you. So sometimes it can cause a change in libido. There was a question about birth control pills, and as I say, PCOS is usually, if you're not trying to get pregnant, managed with birth control pills. So what the birth control pills do is they actually suppress the hormone production. So it's just giving you a level state of your hormones. And then with the progesterone dropping when you have the sugar pills, that's then causing you to have a period, to make sure that the lining washes away every month or every 3 months, depending on which birth control pill you're taking.